All right, so yeah, what Catherine was saying is I'm gonna talk to you about the research I had the pleasure of doing this year, to using thermal imaging to determine vascular patency. So, kind of to start, I'll just give a little introduction about the project itself and kind of some background information. So, first, muscle flaps, grafts, anastomoses, and other interventions are commonly used to reconstruct areas of the body, preserve tissue, and bring healthy blood flow back to devascularized areas. So kind of what we think about this is we can think of a STEMI, a blood clot, brain aneurysms, maybe like a reconstruction like of the breast, the brain, etc. Different modalities where there is blood flow that's cut off to a certain part of the tissue, causing tissue to die essentially. So when it comes to these things, there's different imaging modalities that are used to determine blood flow and then kind of help with revascularization. One of those things is indocyanine green video angiography, which is just kind of a little dye that can turn green and also can be in more of a monochromatic view. There's digital subtraction angiography, and then there's vascular Doppler ultrasound. These are kind of all like the um, care or the standard of medicine when it comes to things like this. So kind of what I wanted to go through was seeing how infrared thermal imaging was used to assess patency of the inferior epigastric artery, as well as assess stenosis and microcirculation to see if it would be of use, especially in an intraoperative setting. All right. So just kind of extend off that here on the left, this image is digital subtraction angiography of the vessels in the brain. So kind of what you'd think, especially in more of like a fluoroscopic setting, especially when someone has a STEMI, you can kind of some dyes and radio contrast dyes injected into the coronary vessels. You can kind of picture the outline of the heart a little bit. You can detect if there's any stenosis. You can see if there's any aneurysms, etc. And then on the right, we have an example of indocyanine green, which is used in a gastric conduit perfusion for an esophagectomy. So we can see the green overlay depicting the vessels where they're kind of supplying the different parts. And then you can see it in more of a monochromatic view. So kind of like what we talked about or what I just said is in DSA is very common for like coronary artery assessment, especially with someone presenting with chest pain or maybe having a STEMI or NSTEMI. So kind of how I went about this is I took all the cadavers from the Kansas City campuses and Joplin campuses here at KCU, included 54 formalin embalmed cadavers. I took a dissection of the anterior abdominal wall to expose the left inferior epigastric artery. And kind of what I did is I went from the bottom of the sternum, so where the xiphoid process is, all the way down to the pubic symphysis, making sure to keep intact the umbilicus. From the pubic symphysis and then from also the xiphoid process, I extended them out laterally, more to the side of the body, especially from the pubic symphysis to the superior margin of the iliac crest. And I made sure not to damage the inguinal ligaments since those still need to be intact for the students during the year. And from the xiphoid process, I went laterally along the costal margin. From there, I reflected the skin flaps in the adipose tissue over to the side, and then I exposed the anterior abdominal sheath. From there, I also cut that midline, and I reflected it laterally. From this point, this is when I gathered some hot water just from the sink, and I usually kept it around 115 degrees Fahrenheit. And I used a 26 gauge needle and 20 milliliter syringe to inject the inferior epigastric artery. And I also used a FLIR One Edge thermal imaging camera. So this was just like a camera that I could Bluetooth to my phone. It had different settings on it. It had like a normal setting, what you'd see in a normal picture you take on your phone. And then I used the infrared setting. That way I could detect temperature of the water and of the cadavers. And then I recorded a video of the injections taking place. Once I had all those taken, uploaded to my computer, I took still images of the before and after of how the injections took and how the vessels uptook the saline solution. So from there, I just took a qualitative assessment of general patency, stenosis, and microcirculation from the images. And kind of how I went about assessing that, especially for general patency, I just tracked the primary vessel along its course, so the inferior epigastric artery, making sure it stayed open. You could usually see the walls and kind of like the margins of it. Made sure I tracked it all along the way, and I made sure to inject just distal to the inguinal ligament, and that's how I went about it, just so I had much more room to work with. For microcirculations, this just depicted some really small vessels and maybe a general glow coming from the tissues, and I made sure when I was doing this, I could see that there wasn't any leakage as well. And then to see if there was any stenosis. So how someone could see stenosis, especially using infrared thermography, you would see a darker color outline along the vessel tract, or you may see just a complete occlusion of the vessel. And later on in this presentation, I'll kind of show you some examples of the images I took from the project. Then here are kind of my results from the project itself. So this table is just showing the total numbers that were from the KC and Joplin campuses combined, assessing microcirculation stenosis and general patency. In about almost 13% of the cadavers, I saw some microcirculation, which really wasn't a high number, something I wasn't really fond of, I guess. I wanted to see if there would be a higher percentage, just because that's something that's really important, especially within any procedures with patients. In stenosis, I detected 31.48%. In general patency, I could see 98.15%. So the microcirculation I wasn't too happy with. There's a lot of things that could kind of contribute to that, and I'll kind of go over those a little later. And then stenosis, this can be kind of something that may be misleading, this percentage, just because not everyone is going to have stenosed vessels. And I don't really know exactly why the stenosis has occurred. This could be someone that had high blood cholesterol, where cholesterol deposits may be blocking the vessels. It could be a blood clot itself, or it could just be from the preservation process of the formalin embalming period. And there definitely was, I remember one on the Kansas City campus for sure, that there's a huge clot within the inferior epigastric artery, and it was probably from the embalming period. But that's just something we just kind of have to deal with. So here's kind of what I was talking about. Let me get a pointer. So this image on the left, this is figure A. This is one of the cadavers back in Joplin. So we can kind of see along the course where my laser pointer is some general glow. This is showing really good microcirculation. I remember this certain cadaver had a lot of branching points from the inferior epigastric artery. A lot of this is going into the tissue, the rectus abdominis, and the rest of the abdominal wall. And kind of that black arrow is where we're seeing a lot of that microcirculation, and there's good patency along it, which is great. And from about here, where this is about where the rectus abdominis is at, right here. And then on the right, we can see there's general patency. So you can see the needle. This is inserted into the inferior epigastric artery. You can see nice general patency along the whole thing. Sorry, this number's in the way, given the temperature. But you can see the outlines of the walls of the vessel. And then as you go more distal from the vessel, you can see the white arrow pointing to just a complete occlusion of the vessel. So right here, again, I don't know if this is going to be something from cholesterol deposits. I don't know if it's from a blood clot or just from the embalming period. But as we can see, there's really no color change going distal to that site, meaning there definitely was an occlusion in this person. So kind of how I discussed and how I kind of thought of this. So vascular patency, it's really critical in a ton of surgical procedures, especially with the heart, maybe the brain as well. And as we know, a lot of these procedures, when I was talking about digital subtraction angiography, indocyanine and green angiography, is something that you have to use a radio contrast dye for. So a lot of this application can be very dependent on patient comorbidities, renal function, and which can limit its use. So it's not someone that's going through chronic kidney disease or severe renal failure, you really want to use a dye with. Kind of like how the MRIs or CT with contrast, you wouldn't want to do the same thing. So kind of from this, I kind of saw that thermal imaging has a pretty high efficacy in detecting surface temperatures. So again, this is a big reason why you could really only use this intraoperatively. And since it only detects the surface temperatures, I can't use this when someone's closed up if I needed to detect vessels in the brain or within the heart, unless it was an open heart surgery and you're doing a CABG and you wanted to assess. But it is quick and effective in detecting vascular defects. Again, not having to use dye in injecting period. is super quick. For this, I can basically use just a regular blood flow in someone, and then this can help reduce operative times, decrease complications, and eliminate the process of really having to assess renal function, which is something I think that's really important. So for conclusion, thermography is something that can provide a very accurate, time-sensitive evaluation of vessel patency intraoperatively. This can also be helpful in determining location and severity of vessel stenosis, saying if something needs to go back to repair a vessel or make sure we get any blood clots, cholesterol deposits out. This can also help reduce procedure time and decrease complications. Again, as we don't have to use radio contrast dyes for this, you could just use normal saline solution, or you could probably use the regular blood flow as well. And then really no conclusions can be made in regards to detecting microcirculation due to the limitations of the study. Again, 54 cadavers is really not a high sample size, and the camera quality. I don't have a $10,000 camera or anything, so I was kind of limited with the uses that I had. But I think with better technology and everything, I think this could be really helpful in more of an intraoperative capacity. So kind of from that, in the future, it would be great to see larger sample sizes and make sure we use this in real time for real patients so we can further investigate a lot of how it detects vessel patency and then seeing also microcirculation and stenosis. So, and there was one study I had through this research is about a procedure for Moyamoya syndrome, which is kind of a narrowing of the distal internal carotid artery. Can kind of present with stroke-like symptoms in patients, maybe like a TIA. And so in the procedure, they used infrared thermography, just kind of what I did, and they made an anastomosis between the superficial temporal artery, I believe it was, and the middle cerebral artery. So it could bypass some flow and have good blood flow to the brain. And the infrared thermography for their study proved very useful in detecting any stenosis and see how the anastomosis ended up being. So that was something I thought that was really cool being used in, high level surgery, kind of like that. So, and then here are my sources.